Welcome. This is Dr. RAJU DEVDE, Professor of Pharmacology, Kaktiya Medical College, Warangal. So, the topic for discussion today is HIV, AIDS, and antiretroviral drugs. So, before going into the details about the antiretroviral drugs, I would like to give you a brief introduction regarding the HIV and AIDS. HIV is called as human immunodeficiency virus. And the first case of AIDS was described in the year 1981. HIV is of two types, HIV-1 and HIV-2. HIV-1 was identified in the year 1984, and it had several subtypes varying from A to Z. And these subtypes are based on genetic material, and HIV-1 is very common and has a very high rate of replication. Then HIV-2 is less common among the two, and it was reported in the year 1986. When we talk about human immunodeficiency virus, it belongs to lentivirus group and the subfamily of Retroviridae. So HIV virus, it is a retrovirus. So what do you understand by retrovirus? So retrovirus, the HIV virus, the retrovirus is something which the genetic information or genetic material is present in the RNA of the virus. So HIV virus is primarily a RNA virus. The genetic information is stored in the RNA. But when the virus infects the host cells, that the human cells, could be the CD4 cell or macrophages or the brain cells, etc. The genetic information which is present in the RNA has to be converted into DNA. So the information RNA which is present in the RNA has to get converted into the DNA. So we have an enzyme, reverse transcriptase. So this reverse transcriptase, it converts the single-stranded HIV RNA into the double-stranded HIV DNA, which then gets incorporated in the human genome, that is the human DNA, which is a double-stranded DNA. That is the reason why HIV virus is called as a retrovirus. Then, when you look into the other viruses or the other viral infection viruses, similarly, the HIV virus is also not having the cell wall, but rather it has an envelope with a diameter of 120 nanometers. And this envelope consists of various glycoproteins and a protein coat. And the genetic material in the HIV virus consists of two identical RNA strands, which are single-stranded RNA. And there are different enzymes which are present in the HIV virus. One is the reverse transcriptase, the other one is the integrase, and the other one is the protease. So reverse transcriptase, integrase, and protease are the enzymes which are present in the HIV. Now, we'll look into the other details regarding the problem of HIV and AIDS across the globe. So when you look into the HIV infection or the AIDS, it is a global health problem. AIDS has become a pandemic now, and more than 95% of the people living with HIV or AIDS reside in the low and middle income countries. Apart from that, 50% of the infections are seen in the females, and around 2.5 million are children who are infected less than 15 years of age. Apart from that, a significant proportion of the people, that's around 25%, are unaware that they are HIV positive. Why it is so is because people may live with HIV with no manifestations of the disease. So HIV positivity and AIDS are two different entities. For example, a person can be HIV positive and can be asymptomatic up to 2 to 8 years. It depends upon his immune status. So a significant proportion of people, around 25%, are unaware that they are HIV positive. And when we look into the ethnic groups and the racial involvement, the racial and ethnic minorities continue to be disproportionately affected by HIV virus. And the risk factors being the strongest for excess of mortality is the viral load greater than 300 copies, greater than 400 copies per milliliter. If the viral load is more than 400 copies per milliliter, CD4 cell count reduces below 200 cells per milliliter, and there is an infection, opportunistic infection like cytomegalovirus retinitis, it has a strongest risk associated with mortality with HIV and AIDS. And coming to the availability of antiretroviral therapy nowadays has finally resulted in the decline in HIV-related deaths or HIV-related death rates. So availability of the antiretroviral therapy has resulted in the declinement of HIV-related deaths. But when you look at these antiretroviral drugs, they also are going to act at various stages in the replication of the retrovirus. These drugs are not going to act upon the virus which is in a dormant stage. So this one particular thing you have to understand. Not only that, most of the HIV or antiretroviral drugs available cannot cross the blood-brain barrier. Hence, if the infection is percolating to the central nervous system or the brain, no drug is available which can cross the blood-brain barrier and try to act on the brain-related HIV infection. So these are the limitations with antiretroviral drugs. Now, the HIV attacks and binds to the specific cells of the immune system. So here, the human immunodeficiency virus, it mainly attacks to the specific cells of the immune system, which include the monocytes, the macrophages, the T lymphocytes, and the brain cells. That is the dendritic cells of the brain, where the CD4 receptors which are present on the HIV virus are essential or helpful for binding. Then apart from that, we have the CCR5 and CXCR4. They are the chemokine co-receptor proteins. These chemokine co-receptor proteins are helpful for the viral fusion with the host cell, finally resulting in the conformational changes to the key HIV proteins, especially the GP41 and GP120. That is glycoprotein 41 and glycoprotein 120. They are also helpful for conformational changes, and they are the key HIV proteins. Then finally, the HIV fuses and releases its contents in the host cell. So a detailed information I will be giving in my next slides. Now, you have to very carefully look at this slide, a very important slide, which is nothing but the natural history of HIV infection. So when you look at this slide, it has the x-axis. On the x-axis, we do have the time frame from the infection, time frame from 0 to 11 or 12 years. That is the x-axis. When you look into the y-axis, on the left-hand side, the left arm of the y-axis is denominated by the CD4 cell count. And the right hand or the right arm of the y-axis is the viral load. Okay, so x-axis is the time frame, y-axis left-hand side is the CD4 cell count, and the right side it is the viral load. Now, once the virus it infects the human cells, this is called as a primary infection. The virus has gained entry into the host cell with a primary infection, and when you look at this particular point, the CD4 cell count is around 1,000 cells and the viral load is almost a 0. But within a couple of weeks, for example, up to 6 weeks from the time of infection, the CD4 cell count drastically reduces to around 500 cells, and the viral load it increases to around 900 viral copies. So this particular time, the primary infection, to the decrease of the CD4 cell count and increase of the viral load, which is called as the primary infection. So this is called as the primary infection. So this primary infection, it is possible. So this particular point of time from 6 weeks to 12 weeks, or for example, 4 weeks to 12 weeks, it is called as the possible acute HIV syndrome with a wide dissemination of the virus settling into the lymphoid organs. So this is an acute HIV or acute viral syndrome or acute HIV syndrome, where the patient, after the virus gains entry into the host cell from 6 weeks to 12 weeks, there's a decreased CD4 cell count, an increased viral load resulting in an acute febrile-like illness or acute seroconversion illness of HIV. Then apart from that, if you look at after a couple of weeks, like 6 weeks, the CD4 cell count again starts to increase. So once the CD4 cell count increases, the viral load also drastically reduces. And this is an area from 12 weeks to say around 8 to 9 or years, or for example, around 7 years, from 1 year to 7 years. This particular period is called as the clinical latency, or where the symptoms of HIV or AIDS, they are not seen. So this particular phase is called as an asymptomatic phase after an acute seroconversion or seroconversion illness, followed by a clinical latency where the CD4 cell count increases and the viremia it reduces. Then when you look at a stage where again at say 8 years or so, there is a depletion of the immunity and there's an increased viral load. So you can see there's an increased viral load over here. The viral load keeps on increasing and the CD4 cell count, it gets reduced below 200, comes to 150 and almost 0, where we have certain indications here at the age or at the time of 8 years, from latent period of 6 to 7 years, depending upon the immunity, there are appearance of the constitutional symptoms. There is appearance of the constitutional symptoms. Okay. Not only that, the opportunistic infections also are seen at the CD4 cell count to around say less than 100. We come across a lot of opportunistic infections, And finally, there is a death, results in death where the CD4 cell count is very much reduced. And when you look into the viremia or viral load, it keeps on increasing. So here, when you talk regarding the natural history of HIV infection, it mainly depends upon the CD4 cell count and the viral load. As the CD4 cell count is more, the viremia is less. As the CD4 cell count reduces, the viral load increases, with a resultant development of constitution symptoms, with a resultant development of opportunistic infections. And this particular area is not controlled with appropriate antiretroviral therapy, it may result in death. Now, this slide, it mainly depicts, actually, on the x-axis we have time and the y-axis we have the CD4 cell count. This is natural history of HIV infection with respect to the clinical symptoms. And if you look at this particular slide, as the CD4 cell count, it gradually reduces to from 500 to 200 cells per cubic milliliter. We have the symptoms like vaginal candidiasis, the skin diseases, fatigability, bacterial pneumonias, herpes zoster infections, hairy cell leukoplakia, oral thrush, fever, diarrhea, and weight loss. So these are the symptoms which occur when the CD4 cell count reduces from 500 cells to around 200 cells. And if the CD4 cell count reduces below 200 cells to less than that, there is a resultant development of opportunistic infections, especially the malignancies are seen over here in this particular reduction of CD4 cell count below 200 cells per cubic milliliter of blood. So we do have Kaposi sarcoma, which is a malignant tumor, non-Hodgkin's lymphoma, pneumocystis carinii or pneumocystis zerovecki pneumonia, toxoplasmosis, esophageal candidiasis, cryptococcosis, cytomegalovirus infection, Mycobacterium avium complex, and CNS or central nervous system lymphomas. These are all the dreadful symptoms or opportunistic infections. And finally, there is associated death. If there is esophageal candidiasis, cytomegalovirus retinitis, pneumocystis carinii pneumonia or Zerovecki pneumonia, then this particular disease is in a drastic progression resulting in fatality. So this particular slide depicts the natural history of HIV infection with a relation to the manifestation of symptoms with the decrease in the CD4 cell count from 500 to below 200 and below 100, the various symptomatology of the disease. So you would have now by this time understood what kind of a disease this HIV and AIDS is, and it is mainly associated with the CD4 cell count, and it is associated with viral load or viremia. Now, within this slide, I would like to focus our emphasis upon the structure of the HIV. As I told you already that HIV or human immunodeficiency virus, it is a retrovirus because the genetic material or the genetic information of this HIV virus is stored in the form of an RNA. So we have a single-stranded RNA, two identical strands of the single-stranded RNA are present. So these single-stranded RNA are present. Apart from that, in the nucleus of this particular HIV, there are certain enzymes. So the enzyme which is called as reverse transcriptase, which is also called as P64. Then we have a integrase enzyme. So these enzymes are very much essential in the replication of the virus. So it is called as P32. The integrase enzyme is called as P32. And we have the protease enzyme, which is called as P10. Surrounding this core or this particular genetic material, the RNA, the enzymes, we do have the core protein, which is called as P24. And surrounding that is the cytoplasm, and then it is an envelope. So this envelope mainly consists of the envelope proteins, especially the matrix protein is present surrounding the nuclear or the genetic material. There's a matrix protein which is called as P17, and we have certain envelope proteins like GP41 and GP120, which are envelope proteins which are very much essential during the process of binding or fusion and entry of the virus into the host cell. Now, with this particular information of the HIV cell, especially, as I told you that the single-stranded viral RNA is transcribed through the reverse transcriptase enzyme, which is also called as RNA-dependent DNA polymerase, into a double-stranded proviral DNA. And this double-stranded proviral DNA is subsequently incorporated into the host cell's genetic material by the enzyme integrase. Hence, the HIV then uses the host cell's machinery to translate, to transcribe, and produce immature viral particles that later on result in budding and break from the infected cell. And for these immature virions, or the buds of the virus, to become infectious, they have to get matured and they have to be translated into a mature virus. And this happens in the presence of a protease enzyme, which cleaves the large precursor polypeptides into the functional proteins. So we will look into this particular life cycle of the HIV cell in the next couple of slides. Now, this is the life cycle of the HIV cell. In the first stage, if you look at, there's a free virus available which is ready to infect the host cell. So this free virus, it consists of the co-receptors. So it consists of the co-receptors. So these co-receptors which bind to the CD4 receptor present on the host cell. So these co-receptors, or the chemokine co-receptors, are CCR5 and CXCR4. So this chemokine co-receptors which are present on the viral aspect of the HIV, side of the HIV, are going to bind with the CD4 cell receptors. So this is called as binding and budding, where the virus binds to the CD4 cell molecule, and one of the two co-receptors, either CCR5 and CXCR4 receptor molecules, are common on the cell surface. Then the virus fuses with the cell. After the fusion of the virus with the cell results in the infection. So this virus is now ready to infect the host cell. So the virus penetrates the cell and the contents are emptied into the host cell. And this is called as the infection stage, where the HIV RNA is poured into, or it is emptied into the host cell. And what happens here? Because, you know, the RNA which is present in the HIV virus is that it is a single-stranded RNA which has to be transcribed and get integrated in the host cell DNA. So this transcription process is being taken care by the enzyme reverse transcriptase, or RNA-dependent DNA polymerase. So the single-stranded or the single strands of the viral RNA are converted into the double-stranded DNA by the reverse transcriptase enzyme. And later on, what happens? This HIV DNA, which is converted by the reverse transcriptase into a double-stranded HIV DNA, it gets integrated. So it gets integrated with that of the human DNA. So this integration of the double-stranded HIV DNA is being in the presence of the happens in the presence of the integrase enzyme. So this integrase enzyme is also present in the virus only. So this HIV DNA, it gets integrated with the human DNA in the presence of the integrase enzyme. And this process is called as integration, where the viral DNA is combined with the cell's own DNA by the integrase enzyme. Later on, what happens is after the integration process is over, so this HIV DNA gets incorporated into the human DNA, and there are various processes which occur that is called as transcription. In the transcription process, what happens is when the infected cells keep on dividing, the viral DNA is read and long chains of proteins are formed. That means to say now the virus has entered into the human DNA and it keeps on transcribing, and the infected cell keeps on dividing and there is formation of proteins. So the protein synthesis occurs. So these proteins synthesizes, or the proteins get synthesized, and which results in the formation of assembly of these proteins. And this assembly is nothing but the sets of viral proteins and chains come together, they assemble together, and they fuse with what is called as the host cell or the CD4 cell. Finally, after the assembly, the next process is the budding. In the process of budding, the immature virus pushes out of the cell, taking some cell membrane with it along with that. And the protease enzyme starts processing the proteins in the newly formed virus. That means to say, the protease enzyme is required for budding and also for maturation to occur. So once this particular protein synthesis occurs, with the assembly of the proteins and formation of the virions, which are budding viruses, or the budding viruses, which are immature viruses, with the help of the what is called as the protease enzyme. Further, there is these immature viruses breaks free from the infected cells, and it is free to get free to infect the other cells of the host cells. And this immature virus, later on, what it does is the process of maturation. This immature bud or the virion is released from the host cell, the infected cell. It comes out of the infected cell, and later on, the maturation process occurs. The protease enzyme finishes, and it starts cutting the HIV protein chains into individual proteins that combine and make a new working virus which infects the other cells. So once the HIV virus, which are formed, numerous viruses which are formed after budding and maturation with the help of protease enzymes, are ready to infect the other host cells. Once these viruses, number of viruses which are formed, they are ready to infect the other host cells like macrophages or CD4 cells or the brain cells and the monocytes, etc., etc. So this is exactly the life cycle of HIV virus. So the life cycle starts with the free virus getting binded, it gets fused, it empties the contents of the virus. Then there is a transcription with the help of the reverse transcriptase from single-stranded RNA to double-stranded HIV DNA, which then gets integrated into the genome of the human cell, that is the human DNA. So viral DNA, double-stranded viral DNA combines or gets integrated with human DNA. Later on, in the process of transcription, translation, assembly, protein synthesis, budding of the new virions, and this immature virions, the buds of the immature virions get matured by an enzyme which is called as protease enzyme, and these viruses which are again set free for infecting the other host cells. And this is how the replication of the HIV virus takes place. One is the binding of the virus, fusion of the virus, then it gets incorporated by the enzyme integrase, transcribed through reverse transcriptase. Then we have an enzyme integrase which results in integration of the HIV DNA into human DNA. Later on, we have another enzyme that is a protease enzyme, which is helping in budding, maturation of the virus, and the viruses are ready to infect the other cells. Now, we will look into the classification of antiretroviral drugs. So, after looking into the life cycle of the HIV virus, there are various steps. The virus replicates in various steps, right from binding, fusion, emptying of the contents into the host cell, to transcription and to integration, then protein synthesis, transcription, translation, protein synthesis, budding, immature virus, and the mature viruses which are ready for infection. So we have these drugs available which are used in the treatment of HIV and AIDS. And these drugs are mainly classified depending upon the various steps they are going to inhibit in the viral replication. We do have the drugs like nucleoside and nucleotide reverse transcriptase inhibitors. So these nucleoside and nucleotide reverse transcriptase inhibitors, they are called as NRTIs or NTRIs. Okay, right. Then we have non-nucleoside reverse transcriptase inhibitors like NNRTIs. Then we do have protease inhibitors, the PIs. Then we have the NTRI inhibitors. They are also called as chemokine co-receptor antagonists. So the chemokine co-receptor antagonist or NTRI inhibitors like enfuvirtide. No, I'm sorry. The NTRI inhibitors are the meraviroc, not enfuvirtide, it is meraviroc. Then we do have fusion inhibitors, that is enfuvirtide. Then the last category of drugs which are available are integrase inhibitors. They are also called as HIV integrase strand transfer inhibitors. So these antiretroviral drugs are of 6 types. One is the NRTIs and NTRIs, NNRTIs, the PIs, the NTRI inhibitors, the fusion inhibitors, and the integrase inhibitors. So we will look into the next slide, which is going to depict actually the life cycle and antiretroviral drug targets. So we have looked into the life cycle of the retrovirus. So when you look into this particular slide, you have various drugs available that are going to act at various levels of the multiplication or replication of the virus right from the entry. So we do have this entry inhibitors. So this entry inhibitors, the entry inhibitors are meraviroc, which are going to act at this particular level. The entry inhibitors are the meraviroc. They block the CCR5 receptor. So they are the CCR5 receptor antagonist. Then we have another category of drugs. They are called as fusion inhibitors. So this fusion inhibitor is blocked by enfuvirtide. So this fusion inhibitor, which is the enfuvirtide. And then we have the drugs which are going to act by inhibiting the reverse transcriptase enzyme. So the reverse transcriptase enzyme, which is present here, which is going to act at this level, the reverse transcriptase is going to act at this level. And we have the drugs that is NRTIs. The NRTIs are abacavir, didanosine, emtricitabine, lamivudine, stavudine, jalcitabine, and zidovudine. So the zidovudine is also called as azidothymidine, which is the first drug which was used in the treatment of HIV infection. Okay, and apart from all these drugs, NRTIs, that is nucleos, they are the nucleoside reverse transcriptase inhibitors. That is abacavir, didanosine, emtricitabine, lamivudine, stavudine, jalcitabine, and zidovudine. They are the nucleoside reverse transcriptase inhibitors, except that there's one drug which is called as tenofovir. This tenofovir, it is a nucleotide reverse transcriptase inhibitors, whereas all the others are nucleoside reverse transcriptase inhibitors. So there's another category of drug which is called as NNRTIs, non-nucleoside reverse transcriptase inhibitors. We have the first line or the first generation drugs, second generation drug. That is delaviridine, efavirenz, nevirapine. They fall under first generation category of NNRTI. The second generation category is etravirin, rilpivirine. Etravirin and rilpivirine are second generation NNRTI. They are acting by inhibiting the reverse transcriptase enzyme. Once they inhibit the reverse transcriptase enzyme, there is no formation of the DNA chain. Hence, there's a stoppage in the replication of the virus. So these are the drugs. So one is NTRI inhibitor, we have fusion inhibitors, then we have NNRTIs, and we have NRTIs. Then we have another target of these antiretroviral drugs, which is nothing but the blockage of the integrase enzyme. So once the drugs are going to block the integrase enzyme, the integration of the viral DNA, double-stranded viral DNA, is being inhibited into the human or host cell DNA. And the drugs which are going to act at this level are the raltegravir, elvitegravir, and dolutegravir. So raltegravir, elvitegravir, and dolutegravir are the drugs which are the integrase inhibitors, which block the integration of the viral DNA to that of the host cell DNA. And the drugs which are going to act or block the protease enzyme and maturation of the virus after the assembly or after the formation of protein synthesis and assembly and the budding and maturation of the virus is being inhibited by the protease enzyme, protease inhibitors, as well as the maturation inhibitors. So these drugs, the protease inhibitors and the maturation inhibitors, are going to act at the late viral cycle in the replication of the retrovirus. So what are the protease inhibitors which are helpful by inhibiting the protease enzyme, which inhibits the budding and maturation of the retrovirus? The drugs available, the protease inhibitors are atazanavir, darunavir, fosambrinavir, indinavir, ritonavir, lopinavir, nelpinavir, and saquinavir. So all these words, okay, like atazanavir, darunavir, fosambrinavir, indinavir, ritonavir, or lopinavir, nelpinavir, and saquinavir, they are the protease inhibitors which are going to act on the late replication stage of the retrovirus, which is going to inhibit the budding and maturation of the virus. So here you have to again understand that whatever the amount of antiretroviral drugs are available with us, they are going to act upon the various stages of the viral replication and even before the entry of the virus and fusion of the virus and the reverse transcription or the transcription of the virus, integration of the virus, then the translation or transcription and translation of the virus to the budding of the virus and maturation of the virus. So we do have these antiretroviral drugs which are going to act only on the replicating stage of the retrovirus. Please mind it. So any antiretroviral drug does not act on the virus which is there in the dormant stage. So it is not acting on the dormant stage of the retrovirus. So that is the reason why. And one more important point is once the virus gains entry into the brain, there is no drug available which can cross the blood-brain barrier and target the brain cells which are infected with HIV. With this particular slide, I think I hope you would have understood the entire replication cycle of the retrovirus and the various antiretroviral drug targets. Next, we will move on to the principles of antiretroviral therapy. So when I talk about antiretroviral therapy, it reminds me of HAART. HAART. So what is this HAART? HAART or HAART, it is called as highly active antiretroviral therapy. And it is defined as a regimen which consists of 2 nucleoside reverse transcriptase inhibitors and one protease inhibitor. So two NRTIs and one PI. So two nucleoside reverse transcriptase inhibitors and one protease inhibitor. Or the second regimen is there is NNRTI. No, so I'm sorry. So here in the heart regimen, we will use two NRTIs plus a protease inhibitor or a NNRTI. The second regimen is we use two protease inhibitors and one other antiretroviral agent. So in the first regimen, we do use two drugs of the group NRTIs plus one protease inhibitor or one NNRTI. Or in the second regimen, we do use two protease inhibitors and any one other antiretroviral agent. So what are the principles of this antiretroviral therapy or heart regimen? So the principle or the outcome of this particular antiretroviral therapy is the maximal and durable suppression of viral load has to be achieved. So our purpose for this antiretroviral therapy is to achieve maximal and durable suppression of viral load. Apart from that, ERT should restore or preserve the immunological function of the individual. It has to restore and preserve the immunological function. It has to reduce the HIV-related morbidity and mortality. It has to improve the quality of life of HIV-infected persons. And the prevention of mother-to-child transmission has to be taken care of. And this antiretroviral therapy also is used for post-exposure prophylaxis. It is also used as pre-exposure prophylaxis in a typical entity which is called as non or uncordant couple or discordant couple. So what do you mean by this discordant couple and the role of pre-exposure prophylaxis with antiretroviral therapy or heart regimen? So discordant couple is the one where, for example, a spouse or a male gets affected with HIV. So he is having HIV positive, whereas the female does not have HIV positive, or it may be vice versa. Okay, so once a couple, a spouse or one person among the family, for example, wife and husband, he gets affected with HIV and the wife is not affected with HIV, but the wife has to be given a pre-exposure prophylaxis of antiretroviral therapy or heart regimen along with the husband. This is called as discordant type of manifestation where one of the spouse is affected with HIV, other is negative with HIV. So these are the various principles which are implicated, which are helpful, or these are the principles which has to be useful in achieving the success rate with the treatment of HIV with the help of antiretroviral therapy. Now, we will look into the various drugs that are available according to their mechanism of action. The first group of drugs, they are the nucleotide and nucleoside reverse transcriptase inhibitors. So when I talk about nucleotide reverse transcriptase inhibitors are all these drugs except tenofovir. Okay. Nucleoside reverse transcriptase inhibitors are all these drugs. Nucleoside reverse transcriptase inhibitors are all the drugs except tenofovir. Tenofovir is nucleotide reverse transcriptase inhibitor. So abacavir, didanosine, emtricitabine, lamivudine, stavudine, indovidine, also called as azidothymidine, and jalcitabine, they are nucleoside reverse transcriptase inhibitors. Tenofovir is a nucleotide reverse transcriptase inhibitor. And all these drugs have the abbreviated forms like abacavir is ABC, didanosine DDL, FTC, 3TC, D4T, and all these abbreviations are very much helpful when we go for the regimens of these antiretroviral therapy. We have to remember these abbreviations with respect to all the antiretroviral drugs. Now, when you look into this nucleotide and nucleoside reverse transcriptase inhibitors, these are the first drugs available. These are the first drugs available for the treatment of HIV infection. But when you compare to that of non-nucleoside reverse transcriptase inhibitors and protease inhibitors, they are less potent, but they do have a very important role to play as antiretroviral treatment. They are having high activity against both HIV-1 and HIV-2, and they are the analogs. They are the structural analogs of nucleosides and nucleotides. And apart from that, these particular nucleoside or nucleotide reverse transcriptase inhibitors, they differ from normal substrates only by a minor modification, the sugar moiety or the ribose molecule. Next, the mechanism of action of the NNRTIs, nucleoside and nucleotide reverse transcriptase inhibitors. So these drugs, they are going to interrupt the HIV replication cycle via the competitive inhibition of HIV reverse transcriptase enzyme and result in termination of the DNA chain formation. So what is the function of this reverse transcriptase? Reverse transcriptase is an enzyme which is an HIV specific DNA polymerase. And this enzyme, it allows the HIV DNA to be transcribed into a single-stranded and ultimately a double-stranded proviral DNA, which is then incorporated into the host cell genome. And this pro-DNA, which is a double-stranded DNA chain, gets elongated, which is necessary before the genome, it gets incorporated into the host cell DNA. Okay, so the function of the reverse transcriptase enzyme is the single-stranded HIV RNA is transcribed into the pro-viral DNA, which is a double-stranded viral DNA. And this double-stranded viral DNA, which gets elongated, which is necessary before the genome is getting incorporated into the human or the genetic material. And this reverse transcriptase, it acts as a false building blocks, which causes this chain termination reaction. Next, this is the area where this particular nucleoside reverse transcriptase enzyme is going to act. In NRTIs, they are going to act at this level. They are going to act at this particular transcription phase. So reverse transcriptase inhibitors. Next, the pharmacokinetics of NRTIs. So these NRTIs are prodrugs and they undergo phosphorylation by the intracellular kinases to exert their activity. The oral bioavailability of these drugs extend from 25 to 93%, with the tenofovir and diadenosine on the lower end of the spectrum. That means to say, tenofovir, which is the nucleotide reverse transcriptase inhibitor, diadenosine is a nucleoside reverse transcriptase enzyme inhibitor. These two drugs of the group have very less bioavailability. Food does not significantly affect the absorption of the drug, except diadenosine, which must be taken on an empty stomach. And all the drugs are having excreted through the kidney, with an exception of abacavir. So this abacavir can be given at a normal dose, regardless of the creatinine clearance. That means to say, abacavir is the drug which does not result in development of a renal problem, or even if there is some amount of renal problem, it doesn't, regardless of the creatinine clearance, we can give the normal dose of abacavir, whereas the rest of the drugs like zidovudine or diadenosine or emtricitabine, their doses have to be reduced or they have to be stopped when there is a decreased renal clearance. And these drugs have minimal drug-to-drug interactions, and clinically significant interactions are present with diadenosine. So with diadenosine, when it is combined with tenofovir, the diadenosine levels are higher than expected. That means to say, tenofovir will cause increased levels of diadenosine. So it may result in development of toxicity. And diadenosine should not be combined with ribavirin. So this combination has to be avoided. Okay, now we will look into the individual drug. Abacavir, the name of the drug, the dosage, adult dose and adverse events. So you can just go through these dosages. I don't want to emphasize more on the dosages as the slides are available with you. So we'll look into the adverse drug events of individual drug of NRTIs. Abacavir causes hypersensitivity reaction like fever, rash, nausea, vomiting, diarrhea, malaise, shortness of breath, cough, pharyngitis. And one most important aspect regarding abacavir is patients who are HLA-B positive are at higher or highest risk of developing hypersensitivity reaction. So before initiating the drug abacavir, one has to perform HLA screening. And then only if it is negative, we have to initiate the abacavir drug. Then when we talk about diadenosine, it causes peripheral neuropathy, pancreatitis, nausea, and lactic acidosis. So peripheral neuropathy, pancreatitis, and lactic acidosis are, we can say, the serious adverse drug reactions which are manifested with diadenosine. And emtricitabine has minimal toxicity. It mainly presents with hyperpigmentation. Then lamivudine. So lamivudine is another drug which is available in the category of NRTI. It also has minimal toxicity, and there are certain severe acute exacerbations of hepatitis may occur when there is a concomitant infection with HBV, that is hepatitis B virus. So lamivudine may result in serious acute exacerbation of hepatitis when there's a concomitant infection with hepatitis B infection. Then we have another drug, stavudine. It does have peripheral neuropathy, pancreatitis, lactic acidosis, lipoatrophy, hyperlipidemia. Then this tenofovir, as I told you, this is the only drug available in nucleotide reverse transcriptase inhibitor, which causes nausea, vomiting, diarrhea, headache, asthenia, and renal insufficiency. Then apart from that, if you look at zidovudine, the adverse drug reaction profile is very serious, where it is anemia, granulocytopenia, myopathy, lactic acidosis, hepatomegaly, steatosis, nail pigmentations, lipid abnormalities, and lipoatrophy and hyperglycemia. So zidovudine or azithromycin has a battery of adverse drug reaction profiles. So if you look at this particular antiretroviral drugs, if you take any antiretroviral drug, it does have a lot of adverse drug reactions because it is going to destroy the virus at one particular stage. At the same time, it is causing serious adverse drug reaction profiles with all these antiretroviral drugs. Then we'll go to the next group of drugs. They are NNRTIs. So what are these NNRTIs? NNRTIs are non-nucleoside reverse transcriptase inhibitors. And these drugs were introduced in the year 1996 with the approval of nevirapine. So nevirapine happens to be the first drug in this category which has come into the market in the year 1996. And these drugs are having high potency or high potent activity against HIV-1 virus and are part of the preferred initial regimens in the treatment of heart regime. So efavirenz is one drug which can confer most significant inhibition of viral infectivity. Nevirapine was the first drug introduced in this category, and efavirenz is one drug which is having a very potent in inhibiting the viral infectivity. That is the reason why we have one combination of a regimen of antiretroviral drugs in heart regime, that is TLE, that is tenofovir, lamivudine, and efavirenz. Tenofovir, lamivudine, and efavirenz happens to be more superior regimen when compared to that of ZLN. So ZLN is zidovudine, lamivudine, and nevirapine. So zidovudine, lamivudine, and nevirapine is one regime in heart, and we have TLE, tenofovir, lamivudine, and efavirenz is another regime which is highly potent, and it also has less ADR reaction profile when compared to that of ZLN regime, that is zidovudine, lamivudine, and nevirapine. TL is tenofovir, lamivudine, and efavirenz. All of these drugs, they are going to exhibit the same mechanism of action when compared to that of NRTIs. NNRTIs and NRTIs have the same mechanism of action. So what is the mechanism of action of NNRTIs? So this NNRTIs, these NNRTIs, they act upon the HIV reverse transcriptase, which is a heterodimer composed of two subunits. So this HIV reverse transcriptase, it is a heterodimer which is composed of two subunits, that is P66 and P51. And the nucleoside, non-nucleoside reverse transcriptase inhibitors bind to the P66 subunit at a hydrophobic pocket distant from active site of the enzyme, which is the allosteric site. So this NNRTIs bind to the P66 subunit at a hydrophobic pocket, which is distant from the active site of the enzyme, which is the allosteric site. And this non-competitive binding induces a conformational change in the enzyme reverse transcriptase. And the first generation NNRTIs are more rigid in structure, and they may cause resistance very quickly when compared to that of the second generation NNRTIs, which are more flexible in structure, and they do have a very less amount of development of resistance, as they readily adjust and resist mutation more effectively, and there is less development of resistance with respect to second generation NNRTIs when compared to that of the first generation NNRTIs. So what is the mechanism of action of NNRTIs? It is also effective by inhibiting the reverse transcriptase enzyme. So they are going to act at this level. Non-nucleotide reverse transcriptase inhibitors, they are acting at this particular enzyme, that is the enzyme reverse transcriptase. Then we will look into after the mechanism of action of NNRTIs, we will look into the pharmacokinetics of NNRTIs. All the NNRTIs, they utilize the cytochrome P450 enzyme for metabolism and exert varying induction and inhibition effects on the specific isoenzyme. So these NNRTIs are acting through the cytochrome P450, and they are going to exert either enzyme induction or enzyme inhibition with specific isoform of enzymes like CYP3A4 and CYP2C9. This results in a significant potential for the drug-to-drug interactions. So NNRTIs have a lot of drug-to-drug interactions. For example, delaveridine primarily uses the 3A4, cytochrome 3A4 isoenzyme for metabolism. Nevirapine is also metabolized mainly by cytochrome 3A4 with some secondary metabolism through cytochrome 2B6. So nevirapine has two metabolisms. One is primarily it is cytochrome 3A4 followed by cytochrome 2B6. Then when you look into efavirenz, it is primarily metabolized by CYP2B6 and secondarily through CYP3A4. Then we have another drug that is called as retroviral, which is a substrate for three isoforms of cytochrome P450 like 3A4, 2C9 and 2C19. And these NNRTIs, they are highly protein bound. 98 to 99% of these NNRTIs are plasma protein bound. And apart from that, they bind mainly or primarily to the albumin and alpha-1 acid glycoprotein except nevirapine. So all the other drugs like NNRTIs available in the group, they are highly plasma protein bound. They primarily bind to albumin and alpha-1 acid glycoprotein except nevirapine. Nevirapine does not primarily bind to albumin and alpha-1 acid glycoprotein. Coming to the plasma half-lives, which are fairly longer plasma half-lives extending from 25 to 55 hours, except to that of delaveridine, which has a plasma half-life of 2 to 11 hours. Then apart from that, we will look into the individual drugs, the NNRTIs, and their adverse drug reactions. So delaveridine presents with mainly the rash and headache. So the adverse drug reaction profile with delaveridine is very less. Then when you look into efavirenz, it has adverse drug reactions like rash. Then there are certain CNS adverse drug reactions like somnolence, vivid dreams, confusion, visual hallucinations, and hyperlipidemia. So the CNS side effects are more with efavirenz, and also the endocrinal side effects like there's a dyslipidemia or hyperlipidemia, which is seen with efavirenz. Then we have another drug in this category, NNRTI, that is retroviral. So this retroviral also produces rash, skin rashes and nausea. Nevirapine produces rash and hepatitis. Relpivirine, it produces depressive disorders and insomnia. Now, when you look into the adverse drug reaction profile of these particular NNRTIs, when compared to NRTIs, the adverse drug reaction profile is comparatively less when compared to that of NRTIs. Then we'll come to the third category of the drugs. They are called as protease inhibitors. So these protease inhibitors are the drugs which were first introduced in the year 1955. And these protease inhibitors also form an integral part of the antiretroviral therapy or heart therapy. They exhibit activity against the clinical isolates of both HIV-1 and HIV-2. So the drugs which are available in this category are atazanavir, darunavir, fosartanavir, calcium, indinavir, lopinavir, or ritonavir, nerfinavir, saquinavir, tipranavir. So atazanavir, danuravir, fossamprinavir, indinavir, lopinavir, ritonavir, nerfinavir, saquinavir, and tipranavir are the drugs which are present in the category protease inhibitors. So they were introduced in the year 1995. Now we will look into exactly how these protease inhibitors they are going to act. If you look at the mechanism of action of protease inhibitors, the HIV protease enzyme is a 99 amino acid aspartic acid protein which is responsible for maturation of the viral particles in the late viral life cycle. So HIV protease enzyme is a 99 amino acid aspartic acid protein responsible for maturation of viral particles in the late life cycle of the virus, HIV virus. So systematically, the protease enzyme cleaves the individual proteins from the GAG and GAG-POL polypeptide precursors into the functional subunits for viral capsid formation during or shortly after viral budding from an infected cell. What does it do? It systematically cleaves the individual proteins from GAG and GAG-POL polypeptide precursors into the functional subunits for viral capsid formation during or shortly after viral budding from an infected cell. So these protease inhibitors are the competitive inhibitors of the viral budding. Okay, they are the competitive inhibitors, the protease inhibitors which will prevent the viral budding. And not only that, they directly bind to the HIV protease and prevent subsequent cleavage of the polypeptides. Okay, so the protease inhibitors are very helpful. They act upon the late phase of viral replication. So this is the area where these protease inhibitors are going to act. That is the late phase of viral replication, where there is budding, maturation, and so on and so forth. Now, we will look into these protease inhibitors which are going to act on the late stage of viral replication. So what are the pharmacokinetics of protease inhibitors? When you look into the pharmacokinetics of protease inhibitors, there is a significant first part metabolism by cytochrome P450 enzymes, that is the isoforms like 3A4 and 3A5, and they are associated with intestinal efflux proteins. They are called as P-glycoprotein is observed. So the P-glycoprotein is a primary and efflux protein. So there's a significant first pass metabolism of CYP3A4 and 3A5, and there's an intestinal efflux which occurs with respect to the protease inhibitors by P-glycoprotein. So the bioavailability keeps on reducing because an efflux of the drug which occurs due to P-glycoprotein. These protease inhibitors are also highly plasma protein bound to an extent 97 to 99%, and they are primarily bound to albumin and alpha-1 acid glycoprotein, except indinavir. Indinavir is not primarily attached to albumin and alpha-1 glycoprotein, and these particular drugs have a very short plasma half-life because of this efflux protein mechanism as well as the first pass metabolism. So they have very short plasma half-life, ranging from 1.5 to 2 hours for indinavir and 7 hours for atazanavir. So for atazanavir, 7 hours is the plasma half-life. Indinavir, 1.5 to 2 hours is the plasma half-life. There is a significant interactions with medications cleared through cytochrome P450 isoenzymes. And low-dose ritonavir, like 100 to 200 milligrams, is frequently co-administered with other protease inhibitors to block the intestinal and hepatic cytochrome 3A4 metabolism. So here we are going to add a low-dose ritonavir along with another protease inhibitor which is going to block the intestinal and hepatic cytochrome 3A4 metabolism. This is regarding the protease inhibitors which are going to act at various at the late replication cycle of the HIV virus at the level of budding and so on and so forth. Now we will look into the individual drugs, the protease inhibitors, and their adverse drug reactions. Atazanavir, that does cause an adverse drug reaction profile like indirect hyperbilirubinemia. There is a prolonged PR interval, so there is a cardiac problem with this particular atazanavir, hyperglycemia, skin rashes, and hyperlipidemia. is one of the major adverse effects with atazanavir. Darunavir, it causes rash, nausea, diarrhea, hyperlipidemia, and hyperglycemia. Darunavir. Then we have another drug, fosfampreenavir, and all these drugs are available in the oral preparation. Some are also available as intravenous preparations. So when you look into fosfampreenavir, it causes rash, nausea, vomiting, diarrhea, hyperlipidemia, and hyperglycemia. Indinavir, it mainly causes nephrolithiasis, nausea, indirect hyperbilirubinemia, hyperlipidemia, and hyperglycemia. So one common observation with respect to that of the protease inhibitors are these protease inhibitors, they are mainly resulting in causation of adverse drug reaction profile with respect to the endocrinological side effect profile, which is more like hyperlipidemia, hyperglycemia, which is very commonly seen with all the four or all the class of drugs, the protease inhibitors. So whenever we are giving protease inhibitors, we have to monitor for the endocrinological side effects like development of increased cholesterol, increased sugar levels, and other effects like involvement of the liver and so on and so forth. So protease inhibitors has this kind of adverse drug reaction profile like endocrinological, hyperglycemia, dyslipidemia, and so on and so forth. Apart from that, we have lopinavir, indinavir, or ritonavir, sorry. Lopinavir, ritonavir, it causes asthenia, hyperlipidemia, hyperglycemia. Nelfinavir, it causes diarrhea, hyperlipidemia, hyperglycemia. Ritonavir, it causes again hyperlipidemia, oral paresthesias, hyperglycemia, asthenia. Saquinavir, it causes hyperlipidemia, hyperglycemia, and there's an increased QT interval. Increased QT interval, increased PR interval. Atazanavir and saquinavir. Please remember, atazanavir and saquinavir, they do have the cardiac involvement. Atazanavir, which causes increased PR interval, saquinavir may also cause increased PR interval and QT interval prolongation. And there's another drug which is called as typrenavir, which has hepatotoxicity, hyperlipidemia, hyperglycemia, and intracranial hemorrhage. So this is an additional adverse drug reaction which is seen with typrenavir. Typrenavir, apart from hyperlipidemia, hyperglycemia, hepatotoxicity, cause increased intracranial hemorrhage, chance of intracranial hemorrhage. So all these protease inhibitors, they do have the common side effects like hyperglycemia, paresthesia, hyperlipidemia, asthenia, nausea, vomiting. Then there's an increased PR prolongation with atazanavir, increased PR and QR interval prolongation with saquinavir, hepatotoxicity with almost all the drugs which are available as protease inhibitors. So when you look into the adverse drug reaction profile, we have to be very careful when we are giving these protease inhibitors for the management of as antiretroviral therapy. Okay, so they have in common serious adverse drug reactions which are manifested with these particular drugs. Apart from that, we do have the fourth category of drugs. They are called as NTRI inhibitors. So these NTRI inhibitors are also called as chemokine co-receptor antagonists or CCR5 co-receptor antagonists or chemoreceptor co-receptor antagonists. In this particular category, we have Maraviroc, which is designated by MUC. And this particular NTRI inhibitors, they act by binding of GP120 HIV surface protein to CD4 cell receptors, which induces a structural change that reveals V3 loop of the protein. So this Maraviroc, it binds the GP120 HIV surface protein to the CD4 cell receptor that induces a structural change which reveals in the V3 loop of the protein. So this V3 loop then binds with a chemokine co-receptor, principally either by CCR5 or CXCR4, allowing the GP41 to insert itself into the host cell and leading to fusion of the cell membrane. So here, the NTRI inhibitors utilize the GP41 of the virus to bind with the chemokine co-receptor or the CD4 receptor and insert itself into the host cell, leading to the fusion of the cell membranes. So this Maraviroc selectively and reversibly binds to the CCR5 co-receptor, blocking the V3 loop interaction and inhibiting the fusion of the cellular membranes. So This is a fusion inhibitor, the mechanism of action of fusion inhibitor. As some viral strains may use an alternative chemokine co-receptor, that is CXCR4 for the entry. So, to know this, a tropism assay is necessary to confirm that the patient's virus only utilizes CCR5 for entry. So, to know whether it is utilizing CCR5 or CXCR4, there is an assay which is called as tropism assay to confirm that the patient virus only uses the CCR4 for the entry of the virus. If you look at this slide, it is only to depict the mechanism of action. You can see this is the RNA of the HIV, and this is the GP1 and GP120 of the virus, and this is the dendrite or chemokine receptor on the host cell, where the CD4 cell receptor is ready to capture this GP41 and GP120. Okay, so the CD4 cell binding results in co-receptor binding, and then viral cell fusion occurs. So this is only to depict how the virus it is going to bind and fuse with the host cell. Okay, we will look into the pharmacokinetics of the fusion inhibitors. For example, if you look into the pharmacokinetics, 75% of the fusion inhibitors or the entry inhibitors or entry inhibitors like Merovirol are early albumin and alpha-1 acid glycoprotein bound. So they are bound to the plasma protein and they primarily bind to the albumin and alpha-1 acid protein. That is your fusion inhibitors. And apart from that, if you look into the half-life, it is extending from 15 to 13 hours, and they are also metabolized by cytochrome 3A4, and it is a substrate for the efflux P glycoprotein. That means to say the plasma half-life of these drugs, like the fusion inhibitors, can be affected by the efflux glycoprotein, and the dose adjustment is required when it is administered in a combination with potent inhibitors or inducers of cytochrome 3A4. Okay, so once this particular drug is used along with the potent inhibitors, cytochrome inhibitors or the enzyme inhibitors or enzyme inducers, there has to be a dose adjustment. Suppose it is used the inhibitors, the dose has to be increased. If it is used the inhibitors, dose has to be reduced. If it is used with the inducers, dose has to be increased, for example. So when the inhibitors are used along with the fusion inhibitors, we have cytochrome P450 inhibitors, the dose has to be reduced. If the dose has to be increased when it is used along with the enzyme inducers, because it metabolizes the fusion inhibitors, so we require more and more of those. It's very simple. When you use this particular fusion inhibitor along with the enzyme inhibitors, the dose has to be reduced. With enzyme inducers, the dose has to be increased. That is the thing. So 150 mg per oral BID when it is used with the inhibitor, 600 mg per oral BID when this is used with, or the fusion inhibitor, the Merovirol is used with cytochrome P450 enzyme inducers. Now, when you look into the adverse drug reaction profile, it results in causation of constipation, dizziness, cough, pyrexia, upper respiratory tract infections, rash, musculoskeletal symptoms, abdominal pain, hepatotoxicity, and nasopharyngitis. So nasopharyngitis and respiratory infections are seen especially with the fusion inhibitors. Now, when we look into the fusion or say entry inhibitors, or both are same. So we have this fusion inhibitors like enfuvirtide. So Merovirol was entry inhibitor, fusion inhibitor is enfuvirtide. Merovirol was entry inhibitor, fusion inhibitors are enfuvirtide. So this enfuvirtide, it acts extracellularly to prevent fusion of HIV to CD4 or other target cells. Okay, so They act extracellularly to prevent fusion of HIV to CD4 or other target cells. And they block the second step in the fusion pathway by blocking the HR1 region of GP or glycoprotein 41. They block the second step in the fusion pathway by binding to HR1 region of GP glycoprotein 41. This is an envelope protein, and it does not allow the HR1 and HR2 to fold properly, thus preventing the conformational change of glycoprotein 41, that's an envelope glycoprotein, required to complete this final step in the fusion process. Okay, so here, enfiviritide, which is a fusion inhibitor, merovirog is an entry inhibitor. So enfiviritide acts extracellularly to prevent the fusion of HIV to the CD4 cell or other target cells by blocking the second step in the fusion pathway by binding to HR1 region of the envelope GP41. And it does not allow the HR1 and HR2 to fold properly, and hence prevent the conformational change of GP41 required for complete the final step in the fusion process. Now, the dose of enfiviritide is 90 milligrams, which has to be given subcutaneously twice a day. The dose adjustments are not required in patients with renal insufficiency or mild to moderate hepatic insufficiency. So there's one advantage with this. This does not affect the renal system, neither it does affect the hepatic system. So dose adjustment does not require in renal failure as well as in mild to moderate hepatic failure. Dose adjustments are not at all required with fusion inhibitors like enfiviritide. When you look into the adverse drug reaction profile, at the injection site reactions, the patients do have develop pain, erythema, induration, and nodules. Apart from that, diarrhea, nausea, fatigue, hypersensitivity reactions, increased rate of bacterial pneumonia also are seen with fusion inhibitors. Now, if you look at this particular slide shows the various steps and the various drugs which are going to act on the various steps. So we do have this anionic polymers which get attached to the virus. So viral attachment to the host cell with the help of anionic polymers, later on followed by the viral entry. These are inhibited by CD4 cell inhibitors, the chemokine 4 receptor inhibitors like enfiviritide, as well as the merovirog. Then, after the viral entry, there is reverse transcription which occurs, and that is inhibited by NRTIs and NNRTIs. Later on, after the reverse transcription of the viral RNA to double-stranded viral DNA, this double-stranded viral DNA has to get integrated with this viral DNA has to get integrated with the host cell DNA, where the process of integration occurs, and this particular integration is inhibited by the integrase enzyme. And later on, this particular integration process is followed by transcription, translation, with the formation of protein synthesis, and the proteolytic process of the viral proteins are going to be inhibited by the protease enzyme. So the protease enzyme inhibits the proteolytic processing of the viral proteins, and it prevents the formation of budding and new virus particles. So this slide totally depicts the sequelae of events or the replication pathway or the replication processes of the HIV from the gaining the attachment to the entry and fusion to the reverse transcription to the integration, transcription, translation, protein synthesis, budding, immature virus formation, and to the exit of the viruses from the host cell, infected host cell, which are ready for free and ready for infecting the other healthy host cells. So this is one slide depicts the entire picture of different drugs which affect at various stages in the replication of the HIV virus. Now, if you look at the last group of the drugs available, that is the integrase inhibitors. They are also called as HIV integrase strand transfer inhibitors. Integrase inhibitors are also called HIV integrase strand transfer inhibitors. They are also called as INSTI, INSTI. So this INSTI is nothing but integrase inhibitors. So the HIV integrase, what does this HIV integrase do? So it is responsible for transport and attachment of pro-viral DNA to the host cell chromosomes allowing transcription of viral proteins and subsequently assembly of viral particles. This proviral integration involves two catalytic reactions. Number one, the processing in the host cell cytoplasm to prepare proviral strands for attachment. Number two, the strand transfer whereby the proviral DNA is covalently linked to the cellular DNA. So these are the two catalytic reactions. One is processing into the host cell cytoplasm to prepare proviral strands for attachment. Then number two, the strand transfer whereby proviral DNA is covalently linked to the cellular DNA. And these integrase inhibitors, they mainly and competitively inhibit the strand transfer reaction by binding to the metallic ions in the active site. How do they act? They competitively act by inhibiting the strand transfer reaction by binding to the metallic ions in the active site. So what are the drugs available? The drugs available are raltegravir, elvitegravir, and dolutegravir. So this dolutegravir is a newer integrase inhibitor. Once a day medication is available and can be taken separately. It does not require a booster dose. Neither it appears to work. It appears to work against the virus that is resistant to raltegravir or eltegravir. That is to say, dolutegravir, which is a newer integrase inhibitor, can be used once a day and it can be taken separately, not along with other drugs. It does not require any booster dose of this particular drug. And this dolutegravir works against the viruses which are resistant to raltegravir and eltegravir. That is to say, raltegravir and eltegravir resistant viral strains can be effectively treated with dolutegravir, which is a newer integrase inhibitor. It is used as a once-a-day preparation. Now, coming to the pharmacokinetics of raltegravir. So, raltegravir is having a rapid absorption, which can be taken with or without food. It has a plasma half-life of 10 to 12 hours, and it has having a longer half-life in women. So, it is having a longer half-life in women, and it is 83% plasma protein bound. It is metabolized by uridine diphosphate glucuronyl transferase enzyme, UDP or UGT transfer, or UGT1 and UGT2. So it is metabolized by uridine diphosphate glucuronyl transferase enzyme, and other antiretroviral agents may alter the metabolism of raltegravir. And antacids, when used along with raltegravir, decrease the absorption by divergent cation binding. So we never give raltegravir along with antacids, or antacids should not be taken along with raltegravir because they decrease the absorption of raltegravir. When you look into another drug, that is elvitegravir, it is administered with low dose ritonavir. It is administered with low dose ritonavir, which is a protease inhibitor. So ritonavir and eltegravir are co-administered 100 milligrams to reduce its first pass metabolism and the systemic clearance. And the co-administration results in a 20-fold increase in the systemic exposure and a terminal half-life of 10 to 13 hours. And this eltegravir is metabolized through cytochrome 3A4. Hence, this particular eltegravir is contraindicated, or the statins are contraindicated when it is used along with eltegravir. And it is metabolized through UGT, that is uridyl diphosphate glucuronyl transferase 1 and UGT 1A3 and 1A1. And they do have, eltegravir do have drug-to-drug interactions with other medications, and likely because of ritonavir. So ritonavir and elvitegravir does have drug-drug interactions with other medications because of ritonavir. And antacids may decrease the absorption of elvitegravir. So this raltegravir, the side effects are nausea, diarrhea, headache, and creatinine kinase elevations are present, or CPK are elevated, resulting in myopathy, rhabdomyolysis, which are rare. So myopathy and rhabdomyolysis are rare complications of raltegravir. Then when you look into elvitegravir, it presents with nausea, diarrhea, fatigability, and headache, which is the side effect. Now, if you look at this particular drug, which is dolutegravir, dolutegravir, which is a newer integrase inhibitor. Dolutegravir is a newer integrase inhibitor, which is mainly acting on dolutegravir resistant viruses. Then we have another drug which is called as bevirimat. Bevirimat, which is a maturation inhibitor, which is a drug under investigation of treatment of HIV in the late stage of maturation of the virus. Bevirimat, maturation inhibitor, which is effective against HIV, is a drug under pipeline or under investigation. Now, apart from that, if you look at the commercial fixed dose combinations of the drugs available for treating the HIV infection, we do have combinations like zidovudine and lamivudine. So zidovudine and lamivudine are NRTIs. Zidovudine and abacavir. Okay, zidovudine, lamivudine, and abacavir. Tenofovir and emtricitabine. One is a PI and the other one is your NRTI. Then we have a tenofovir. Okay, it's not PI, sorry. Tenofovir is an NTRI, and this is nucleotide and nucleoside reverse transcriptase inhibitor. Tenofovir and emtricitabine. Then tenofovir, emtricitabine, and efavirenz. Okay, so these are NRTIs with a PI. Then we have stavudine, lamivudine, and nevirapine. So these two, stavudine, lamivudine, are NRTIs, and nevirapine is a PI. So we have lopinavir, lopinavir, and ritonavir. So the ritonavir and lopinavir are combined to inhibit the or to prevent the first pass metabolism or to prevent the efflux of the drug via the protease inhibitor. Then we have relpidine or plus tenofovir or emtricitabine. And similarly, we have elbitravir and tenofovir and emtricitabine. So these are the various fixed dose combinations of antiretroviral therapy that are used in especially the treatment of HIV and then after these combinations, if you look at the potential drugs which interact with the protease inhibitors and non-nucleoside reverse transcriptase inhibitors, the drugs which has potential to interact with PIs, protease inhibitors, and non-nucleoside reverse transcriptase inhibitors. The protease inhibitors, we do have statins like simvastatin and lovastatin, azole group of antifungal drugs, anticonvulsant, antituberculous drugs like rifampicin and warfarin, because this rifampicin is an enzyme inducer, anticonvulsants are enzyme inducers, azole antifungals are enzyme inhibitors. Like that, we have midazolam, triazolam, clarithromycin is an enzyme inhibitor, oral contraceptive is an inducible drug, amitriptyline again. These are the various potential drug interactions which can be seen along with the protease inhibitors and NNRTIs. So we need to be very careful when we are using the statins like Simva, lovastatin, azole group of antifungal drugs, anticonvulsants, rifampicin, warfarin, midazolam, triazolam, clarithromycin, oral contraceptive pills, and amitriptyline. These do have the potential drug interaction with protease inhibitors and non-nucleoside reverse transcriptase inhibitors. Then, these anti-HIV agents which are under clinical trials. So we do have NRTIs, that is nucleoside and nucleotide reverse transcriptase inhibitors like elvucitabine. So elvucitabine is NRTI which is under clinical trials. And we have another drugs which are called as IDX899 and TMC278 which are under clinical trials. The protease inhibitors which are under clinical trials are bracanavir. Bracanavir is a protease inhibitor which is under investigation. Then apart from that, entry inhibitors like vicreviroc. So we have meroviroc, entry inhibitor which is there in the market. The entry inhibitor which is under clinical investigation or clinical trials is vicreviroc and Pro-140. Then the fusion inhibitors like P1249, interleukins 2, vaccine development is also under process like BCP1452 and GP160. Then there are various other inhibitors like integrase inhibitors like LB-tigravir. Then we have hydroxyurea compounds like BCX34 and the newer classes of drugs like maturation inhibitors like bevirimat, which is again under investigation. And we have CD4 cell receptor inhibitors like 355 are under clinical investigation. So there are so many drugs which are under pipeline, which are going to come for the treatment of HIV and AIDS. They are the anti-HIV agents under investigation or under pipeline, which may come into the market in due course of time. Now, before I finish this talk on antiretroviral therapy, I would like to conclude my talk with this particular slide to recap the HIV life cycle and the targets of antiretroviral drugs. So please remember the targets of antiretroviral drugs. Number one and two targets, like for example, the drugs which act by inhibiting the reverse transcriptase enzyme are the NRTIs and NNRTIs. Nucleoside and nucleotide reverse transcriptase inhibitors or non-nucleoside reverse transcriptase inhibitors, they act by inhibiting the reverse transcriptase enzyme or the RNA-dependent DNA polymerase enzyme. Then, the third group of drugs which are going to act are the protease inhibitors, which are going to inhibit the late replication cycle of the HIV virus. Okay, the protease inhibitors. Then we have the integrase inhibitors, which are going to act at this particular level of integration of the proviral DNA into the human genome or the human viral DNA. So these integrase inhibitors like raltegravir, elbitagravir, and dolutegravir, they're going to act by inhibiting the integrase enzyme. Then we have the entry inhibitors like maraviroc. We have fusion inhibitors like enfuvirtide. And with this, I think probably you might have understood the life cycle of the HIV virus and the various stages in the replication of HIV virus, and what are the various sites of the antiretroviral drug targets in this replicating cycle. So please remember, like other antiviral drugs, antiretroviral drugs are also going to act on the various stages, right from the entry to fusion, replication, transcription, various stages of replication of the virus up till the budding and formation of the new virus, which is helpful for, which is there for infecting the other host cells. I thank you for the patient listening, and my next session will follow. And I try to end this talk with this. Thank you very much.